Chansky. I'm chair of the Department of Orthopedics and Sports Medicine, and welcome to our colleagues who are watching from Harborview and the VA, and I think also Children's. This morning it's my pleasure to introduce Anders Chen and Chenwei Wu. They're both in the Department of Medicine, and Chen was the co-chair of the QI match program, and he worked pretty closely with Aaron to get that project online. If you don't know about that, that was to develop a UW Medicine-wide database of every quality improvement project going on at any given time. And so we all thought that was a great idea, and my understanding is that Aaron was also a big help with that. And Anders joined the faculty in 2014, and he's the Assistant Program Director for Quality and Health Systems for the Internal Medicine Residency Program. And they both work at the VA taking care of patients when they're not doing their quality work. And Bringe, our resident, has organized today's grand rounds, and it's quality improvement in orthopedic surgery, engaging and educating our trainees and faculty. And before we get to that, one kudos for this morning. I'm sure there was lots of good work in the last month, but we only have one to announce, and that was for Alan Swenson and Thomas Burns, who had some feedback passed along to them to Jennifer Best, who's the Associate Dean in the GME office. So Alan and Thomas, hopefully you're watching. Thank you. And with that, we'll have Bringe come up to introduce today's grand rounds.
Good morning. I have no disclosures. I'd like to start this morning with telling you guys a story. Jim has a very important job interview this morning downtown. His wife's already left, and unfortunately she left the coffee maker on. And she left the empty glass carafe on the burner, and it's cracked. Jim, like most of us, needs some coffee to get started in the morning, so he rummages around and finds an old drip coffee maker. He paces around, waiting for the water to boil, and swallows the cup down. He gets into his car and realizes he left his keys on the counter, and unfortunately he's now locked out of the house. But that's okay. Jim has an extra key under the plant in the front porch. But then he remembers he actually gave that key to a friend last week, and that hasn't been returned yet. He runs next door to borrow his neighbor's car, but unfortunately it's in the shop. He runs down to the bus stop, only to remember that the bus drivers have been on strike for 2 days. He calls for a cab, but is told because of the bus strike it's going to be 2 hours before they can arrive. Jim gives up, calls to try to reschedule his interview, and they politely decline. My question is, what was the primary cause of Jim's failed attempt to reach his job interview? Was this a human error, leaving the coffee pot on, a mechanical failure, the neighbor's car not working, the environment in which he's forced to work, so there being a bus strike going on? Is it a design of the system, a door that automatically locks? Is it the procedure used, only leaving a normal amount of time to get downtown? Or schedule expectations, having a set interview time? And I think we can all agree that's a little bit of the above. Because life is a complex system. There are a lot of complex systems in this world, and we all happen to work in one of them. Hospitals are complex systems for a variety of reasons. There are multiple participants with differing levels of knowledge, training, and expertise. There's a high degree of unpredictability and variation. We have a high reliance on technology and often need to work in a compressed time frame for action. And there are significant external forces that influence the goals, capabilities, and functioning of the system. So modern surgery is a high-risk endeavor, not only due to the technical aspects of the operation, but also due to the complexity of the system within which it occurs. As the system becomes more complex, it poses significant difficulties in mitigating error. There's an inability to accurately transfer information between parties. There are often hidden interactions between subsystems that may not be understood or recognized by the personnel in the system. And the increasing use of sophisticated technology further complicates the entire system. So it is essential that we understand how to analyze, influence, and improve the complex systems we work in. And not surprisingly, the ACGME agrees. So when you look at the language used in the Common and Orthopedic Surgery Program requirements, you'll see a couple of key phrases. First is that residents are expected to develop skills and habits to be able to meet the following goals, which are systematically analyze practice, utilizing quality improvement methods, and implement changes with the goal of practice improvement. Residents are expected to advocate for quality patient care and optimal patient care systems, work in interprofessional teams to enhance patient safety and improve patient care quality, and participate in identifying system errors and implementing potential system solutions. Additionally, it states that the program director must ensure that residents are integrated and actively participate in interdisciplinary clinical quality improvement and patient safety programs. With those goals in mind, I'd like to introduce Dr. Chen to come up and share with us systems improvement training.
Thank you all. Thank you for having me. I'm excited to be here for a number of reasons. One of which is that in my world, in my circles, around both quality improvement and broader health systems, so health policy, economics, payment reform, there's a number of venues in which orthopedic surgery and some of the work that you all do has come into the spotlight recently. And so I'll share a few of those with you. I also get to show, sorry, I have no disclosures. I also get to show this slide, which I never get to show to orthopedic surgeons. But this is an orthopedic surgeon, probably in his generation, was more than a strict orthopedic surgeon. And you probably remember him for different reasons. But does anyone recognize this person? It's the same person, 3 different pictures at different phases of his life. So it's Ernest Kahneman. Kahneman exercises presumably are still in your lexicon, so I hear. But he really was one of our grandfathers of quality, and he advocated for hospital reform, outcomes management back in the early 1900s, and the term that he pioneered was called end result cards, which doesn't really exist today. But really what that is the precursor of our quality dashboards that, of course, we see today in a much more virtual version in our Patients Are First and excellence dashboards. He advocated for physician-driven quality metrics, which I think is critical. And for this, of course, he was fired from MGH ahead of his time. But he did ultimately help found the American College of Surgeons, its hospital standardization program, which was the precursor to the Joint Commission. So whether or not that resonates as good, bad, or otherwise, he's left an impact on our quality and our standardization, obviously outside of just orthopedic surgery as well. So I wanted to talk a little bit sort of broadly about quality training, how it fits into our sort of health systems training in this era of medicine. And this is a picture of the Institute for Healthcare Improvement's model for change. This is one of many potential frameworks for quality improvement you might see: Lean, Six Sigma, Lean Sigma, terms you may have heard of. This one happens to be one that is readily available for free to trainees and faculty in academic medical centers, and it's a good one. I show it, because whether it's in this framework or any others, the first question is always thinking about your aim, what you're trying to accomplish, and needing to define that in very concrete terms. One of the biggest reasons for failure in quality improvement projects is poorly defined aims, too big a scope. And I usually look at this when I do anything, preparing for a talk, and also thinking about the drivers behind Chen and I being invited to speak today. And so, really one of the questions is, what is your department looking for? Is it really large-scale health system reform? Is it just wanting to not get cited by the ACGME, or presumably probably somewhere in between. And that ultimately I think can help guide what we try and accomplish. So I'll share with you one story that actually, so in my professional society's annual meeting, Society for General Internal Medicine, 2 weeks ago, the plenary session at our annual conference in DC was given by Vivian Lee about the University of Utah, pictured here, and really a lot of focus on improvements in their orthopedic surgery department, amongst many other places. It's one of the ones highlighted, which I'll share today. But really this was an example of very successful, large-scale medical center level change. So, we're not talking really broad health policy or health economics changes, no major changes to how medicine is financed or paid for across the medical center as a whole. But they really had bottom-up and top-down support, starting with institutional leadership. So their CEO of the medical center, also the dean of their medical school, sort of convergent leadership, is a physician. And she is a radiologist, I believe, but one who was really, who when she came in, was quite visionary about, or at least quite clear about what she wanted to do with quality, safety, and cost in the University of Utah. And they really wanted to focus on value. And so what they did is they heavily invested upfront in data, in developing a value-driven outcomes dashboard, including the ability to analyze this at many levels by anyone. So ability to analyze outcomes and costs at the individual encounter level, the department level, individual provider levels, by diagnosis, by procedure, et cetera. And one of the things they found was high variability in the cost for the same procedure, varying by, in this case, orthopedic surgery, by orthopedic surgeon in the department. They took a non-punitive approach. They invested heavily in resources, including training, in this case for them, lean training, project managers, experts, data again, protected physician time, and worked with the department to have physician-driven leadership in terms of defining quality metrics, defining processes for change. And ultimately, after 2 years of their implementation, they came up with this composite quality index, their sort of perfect care encounter, where they took all the quality metrics as they determined important from their own orthopedic surgery department, plus presumably some standardized ones that they have to be accountable for. Quite a significant increase in the number of perfect encounters, reduction in length of stay, and an 11% reduction in cost without any real payment mechanism changes is quite impressive. And then in a different example, I think you're probably more familiar with this, but coming from Medicare, the notion of bundles, of paying based on an entire episode of care associated, in this case, with lower extremity joint replacement, that procedure and all of the care associated with it, with the goal of encouraging coordinated care amongst all providers, surgical, non-surgical, pre-surgery, post-op, nursing facility, et cetera, an effort to standardize best practices, reduce variation, both clinically and financially, with, of course, the goal of improving quality and reducing cost. So, QI done in the large scale requires a lot of things that are not easy. Leadership, support, and vision, yet the space to allow for department or specialty-specific expertise in creating the path forward and determining what are the metrics that are important, autonomy over the process, since each of us is the specialist and the expert in our field, as opposed to the C-suite leadership, department-driven metrics, and hopefully aligning interests and incentives, right? Whether it's the payer from Medicare's perspective, the medical center, the provider, and of course with quality and good care, the patient would appreciate that as well. And then resources. A lot of this big picture change is hard to accomplish without resources. Data, first and foremost, really the ability to understand and believe in your metrics, right? I think a lot of these things go astray when you don't really believe in the metrics that you're being evaluated based upon. Certainly in my field, when we're looking at outcome metrics in diabetes management that aren't fully relevant, it's hard to put a lot of stock or frankly care. Protected time, and then support, whether that's training in quality improvement methodology, project management, things like that. And hopefully these things all get at sort of the bigger picture drivers of motivation. If you follow social science, Daniel Pink, who's written a book called Drive, he gives a TED Talk, and he talks about autonomy, mastery, and purpose. And in order to care, you've got to be able to have some control of the process. You've got to know what you're doing and be allowed to do it well, and you've got to care and believe that it matters. Certainly applies to us in our clinical lives as well as in any quality improvement efforts. So, just to sort of flesh this out a little bit, with the lower extremity joint replacement bundle idea, you've got leadership, in this case, it's certainly pulling from the payer and the purchaser, Medicare, right? There's still demonstration projects in many places, but medical center and Medicare, sort of top-down leadership. But how do you actually do it? How do you improve quality and reduce cost? You better involve the department, the providers who know better than leadership. And it's different place by place, right? It's going to be different at UW versus UCLA versus University of Utah based on different specifics of care here of our providers, of our department. Decide on the right quality metrics. Leadership has to open the door to really obtain the data and again, provide the support, the time for champions and people to work on these processes. As a contrast, there are ways to do QI very poorly as well, which certainly I've seen and been involved with, unfortunately. One example is tell a resident to do a QI project, tell them what they have to work on, give them no resources, especially with data, therefore they're banging their head trying to get the data, waiting, or doing a lot of chart abstraction manually. No training in methods or statistical process control. No alignment with leadership priorities, so they're really working in a silo, trying to do their work without a lot of sort of conceptual or institutional support. And as you can imagine, that can be a recipe for none of these in terms of a feeling of autonomy, mastery, and purpose. Best case scenario, you'll have your sort of positive deviant, the person who succeeds despite all of this, comes up with a great project and it dies as soon as they leave because there's no support or infrastructure to carry it forward. And the worst case scenario is, A, you achieved very little or nothing, but you also spent a lot of time and capital trying to get this going. Nothing happens, nobody's going to want to do it again. The sort of activation energy the next time is going to be even higher to try and impact some change. So going back to aim and scope, large-scale change. Of course, it is important. It can do really great and inspirational things, but it takes a lot of time and resources. And I think the flip side, which we can do really well, and Chen will talk more about this, is day-to-day clinical performance and work, things that we're really generally already reasonably well trained to do based on our clinical expertise and don't need very much additional support other than some good judgment, honestly, and guidance in terms of where to focus your energy, where there are places for, that are ripe for intervention based on what we do and know day-to-day. So one approach, clinical QI and daily clinical practice, understand at the high level, right? So if the situation is ripe, if leadership has prioritized that residents, faculty, or priorities that residents and faculty are interested in, then to be involved in a piece of the project, in the right side scope, and be part of that bigger picture change if it's there. So Kari mentioned the recent ACGME in the orthopedic surgery program requirements, the new common program requirements related to duty hours, or what are no longer called duty hours, that came out a couple of weeks ago, or a couple months ago, also laid out a lot of new language that has not been translated yet into program-specific language. But it really, if you go through painfully, word by word, there's 3 new pages on safety and quality training, and the majority of it focuses on patient safety, and really a lot of language on needing to demonstrate competencies, formal training, applying skills, no more of the old vague language around, being involved, basically. Still a lot of focus, but less on quality improvement, sort of the longitudinal sort of moving projects forward. Again, they state formal training, but optional participation in sort of what I conceptualize as a longitudinal project. And then smaller and less specific language around other aspects of health systems, health economics, policy, cost and value, some of the sort of larger scale concepts around our healthcare delivery system. So just lastly, I will introduce you briefly to what we have tried to do in our residency program over these last 3 years. And the first step was really just building a culture of patient safety, or trying to, within our residency program and in our department, starting from day one. So we don't do a lot in the intern curriculum. It's really a half-day seminar, really just trying to build understanding around the culture of patient safety. And just believe that it matters. No need to understand any of the methodology, just success stories from patients, how things can improve. Believe that your own opinion counts. Success stories from our senior residents who have engaged in successful projects and effected some change in their day-to-day clinical life. And then supporting residents. The notion of just culture, sort of when errors and near misses happen, we first console and want to make sure that everyone is okay, and that we want to learn from it eventually, as opposed to a more punitive approach. Our 2 years when our residents really develop practice improvement skills, so we help pull either their own personal readmissions cases from the UW wards from when they were interns, or real-time PSN reports that the residents themselves have generated, hopefully sort of things that they care more about if it was their own patients or they took the time to submit a PSN report. And we walk them through in a 4-week seminar, half a morning a week for 4 weeks, learning patient safety and quality improvement methodology with their own personal cases. And this past year, as we've done it with live PSN reports, we incorporate it into the actual machinery for patient safety within Harborview and UW Medicine, UW Medical Center, where they report out to our internal medicine representative for MQIC, Medical Quality Improvement Committee, and really have their recommendations and their work influence the actual patient safety work being done at the medical center level. And then our 3 years is really focused on helping at least understand conceptually the big picture, health policy, economics, and delivery systems. This is sort of where we talk about sort of more nebulous things, not just the patient-provider relationship, but really how purchasers and payers impact what we do, patient outcomes, talking about sort of the goals of the triple aim, cost, health, and patient experience, and we add in provider experience as well for the quadruple aim. We talk about getting incentives to align drivers of real cost and waste in the system, sort of not day-to-day quality improvement work, but really at least setting a foundation for understanding some of this bigger picture stuff. And then we have one elective, one major elective, actually 2. One is inpatient focused, one is outpatient focused. The inpatient one is really the quality improvement elective, where we get, we have executive leadership support from Harborview. This one happens to take place at Harborview. We get high priority areas from leadership ahead of time. It's a lot of legwork ahead of time for me and one of the Harborview quality folks to come up with the right project. But we scope it out ahead of time. We have a sponsoring committee within Harborview, something that will actually keep the work moving forward. Protected time for the residents, for faculty, and then multidisciplinary support, including pulling data for them. Not perfect, but something that we're working on. So that's the rough story in our curriculum. Graduated by year, tying it to direct patient care as much as possible. trying to appeal to residents' intrinsic motivations. So, our hospitalists are always here at UW, discharge by noon is an important thing, and it really is important for hospital flow, but it's not the sort of the most appealing thing for residents, right? They feel like it's a little bit of what kind of control do they have? It's not what they care the most about. So rather than focusing on that, we let them work on the issues that they themselves have generated with PSN reports. With that, I will turn it over to Chen. Again, we try our best to inspire a culture of improvement, to train residents to engage in daily practice improvement, and then to understand at least the bigger picture drivers and factors afoot in our broader healthcare delivery system. And Chen is going to talk more about quality improvement in daily clinical practice. I have to leave a little bit early, so I won't be around for questions at the end. So I don't know if anyone has questions for me specifically. Chen can certainly help address many of these as well. But if you do, let me know. Otherwise, thanks for your time in this. Please.
A perfect patient encounter or something like that?
Uh-huh.
Can you clarify what
Sure.
that is? That I've ever had.
Yes, the question was, there was a term earlier about the perfect care encounter, something like that. And that's not a generalized term necessarily in the quality improvement lexicon or with us. That came from University of Utah. So they just developed their own composite quality index. So, taking in all of sort of a handful of their quality metrics that they really cared about, in this case around joint replacements, and created an index and looked at what they were measuring is how frequently did a case meet all of their metrics, check all of the boxes in terms of quality, and that was considered a perfect care encounter. Sure.
So it's interesting that you talk about Utah because I think one of the problems in our system is that we're all somewhat siloed at the different hospitals.
Right.
So most of our total joints are done at Northwest Hospital now, and under the leadership of Paul Manor and Adam Sassoon and Evan Fernando, we've actually got our length of stay down to 2.3 days, and our inpatient costs have dropped well over 11%. I think they're down. I think we can basically offer a cash paying patient now a primary total joint for about $23,000, which is really competitive. And I just don't think people around the system necessarily know about all of that work. But my question is, how do you do this?
I think it's a great question. Utah also has generally healthier people, more active and healthier people, which probably makes it a little easier. No, I certainly don't have any good answers to that. Talking about how UW Medicine and their vision, that's certainly well above my pay grade. In this context, what I would say is, this is probably good reasoning to focus on QI and daily practice. I don't know what the answers from a leadership perspective are, honestly. And it may be that UW Medicine needs to change in the bigger picture. But the other thing that I would say is, as you mentioned, I think we really should champion our successes here, whether for a variety of reasons, but including disseminating knowledge on how to do this. We're all trying to learn together, especially how you do this in a poorer state-funded medical center. I think, across the country, people are trying to figure this out. This is all still, fairly new space without best practices. A lot of demonstration projects, a lot of internal efforts, not a lot of dissemination of best practices yet. So.
Thank you very much for that presentation. You used two terms that I'm trying to reconcile, and that is this theme of standardization and reducing variation, and also autonomy. I find those at either end of the pole. That standardization is great. You know what the job description, you know exactly what to do. It's safer. It can be more cost economic. But autonomy is a cultural principle, as you saw. And so how do you reconcile these two as we begin a project for quality improvement?
Sure. Thank you for that. So, Dave Flum says it one way, which is I don't know where this term has come from, but I've heard him state toxic variation, right? There is plenty of variation in our clinical care that truly doesn't need to be there. How I manage COPD 80% of the time in my clinic, there are best practices. I don't need to deviate from that most of the time, right? And this idea of variation, so this is from the Six Sigma school of thought, that there is a lot of variation that can and should be reduced in order to avoid errors and mistakes. And so I think that is a very real thing in all of our clinical worlds, that there is sort of this toxic variation that doesn't need to be there. Autonomy, I think we all believe as providers, absolutely, our brains are here for a reason, right? Medicine won't yet be replaced just by protocols and algorithms. And so I think there's undoubtedly a need for autonomy in the more complex cases where there are no simple best practices. And then, within quality improvement specifically, again, I think this dichotomy, as you stated it, it makes sense why it seems like a dichotomy, but I think they're not in opposition to each other. There is a lot of autonomy needed from within divisions and departments in order to figure out the best way to standardize our practice, or at least those parts of it that can be standardized, right? And it doesn't all have to focus on standardization. You borrow from different methodologies as it makes sense in your context. Standardization and reducing variation and errors can be the right answer or approach for certain things, and in other cases, that's not your goal, and you're trying to do something else, whether it's a lean approach of just reducing waste and cost. So there are two concepts that fit in certain circumstances and certainly don't have to be diametrically opposed. Thank you. I will turn it over to Chen then.
Hey everyone, I'm the second Chen from whom you will be hearing from this morning. So we're just going to take it. So I just graduated internal medicine residency 2 years ago and did a chief resident year at the VA for quality and safety internal medicine. So this is sort of maybe a little bit closer to the resident approach. Not saying that Anders is old, because he's definitely not, but just a little bit more proximal about how to fit this within maybe your day-to-day workflow, which is really, really difficult, understandably so. So the barriers to change that I've sort of just thinking about this come up with is that number one, we're all really focused on excellent clinical care, and the way that historically we have been talking about QI as this thing on top of clinical care, especially with ACGME kind of coming in and saying you have to do this and not organically developing it from within, is that it can be thought of as a distraction to clinical care, to good clinical care, rather than extension of it. And I want to kind of take the opportunity here to kind of say that that may not be the best way to think about it, and that they're actually more closely related than you might think. And there's lack of formal mentorship or integrated education and QI methods. We're not going to actually delve into too many methods today. I think a lot of that can be learned just in time. And then obviously the big elephant in the room is that there's really no time to do some of the QI that even if you had an interest in, you're just so busy with other things, work and life, et cetera. So that's slightly, we'll get back to that in the future. So the first one I want to talk about is the perception that QI is a distraction rather than extension of good patient care. So when you come to evaluate a patient, there's certain things that you've learned from the beginning of medical school. This is the approach to it. So the first thing that you do is you obtain a history from the patient and any collateral information that you can obtain, family members, caregivers, whomever, the EMS crew that brought them in. And basically you're trying to build the story for why this problem exists. You have the problem in front of you and you're trying to get more information. And the second thing that you try to do, which is all that extra stuff, the social history, past medical allergies, et cetera, is to identify the constraints in which you're working and the context in which this patient is arriving from. And then you examine the patient, you verify some of the theories that you've gotten through the history, and you test it out and see, which of these fit, which of these don't fit. In the meantime, you're just making sure that this person has a pulse, right? So there's certain things you're looking at a monitor to make sure are going all right, and labs that you're getting. So you want to verify objectively. And then you diagnose the problem, and then you initiate treatment. So this happens on a daily basis. This happens, I don't know what your caseload is, but probably, you know, like a half dozen to a dozen times a day. And sort of broken down, this is kind of what it looks like. There's a presenting complaint, you go through your work to arrive at a diagnosis, and then you deploy the indicated treatment. So for instance, if you have a situation where a patient comes in and says, I've got knee pain, this is one possible diagnosis that you could arrive based on the testing that you do and the history that you obtain and your medical knowledge. And then this is maybe what you would recommend. So what I want to emphasize though is that this part, your assessment, is extremely important, right? Because there's multiple things that can cause knee pain. So if it's an ACL tear, that means you want to do something else. And I don't know if any of these are right. This is just what I get from like updating ortho stuff. This is why we consult you all the time for these kinds of things. But this is generally the approach. So this might lead to this, but if you think it's horrible DJD and a patient that can tolerate it, you might go for a total joint replacement. So what you do depends on what you figure out is happening. So in the QI world, this is basically the same thing. So you have what's basically called an apparent cause or the problem that you see and however it manifests itself, whether it's a nurse yelling at you about something, a medical error, or you hating some aspect of your workflow, right? That's the symptom. And then what you have to figure out is the cause of that problem. So, and then you develop an intervention that is directed to fix the root cause. So I'll just go back real quick to this particular photo. So does anyone know where this is or what this is? That's exactly right. So this is the sterile core at Harborview. So she's packing up instruments for a tray for an OR case. And these things are so complex. So this is part of a rapid process improvement workshop that I did last year at Harborview. First time in the ER since med school, completely freaked out by that experience. But basically, you know, it's extremely complex. And she's basically taking the tools that you get from a case, sterilizing them, cleaning them, repackaging them for use in another case, right? So this is a very important part of making sure that your cases go off right. This is a recipe sheet that she's using to make sure everything is packed correctly. So that's basically the context. It's context that you know very well. How many of you guys have been to the sterile core and seen this in action? Awesome, awesome. That's perfect. And part of that, you know, like part of this, like examining the patient or if there's a problem or whatever, is understanding all the pieces, and the best way to understand that is to actually go there. So when we talk about, let's say there's an issue, and this is based on a true story, let's call it that, is that the trays keep coming back with broken equipment. So you start the case, you open the tray, and lo and behold, as you try and get ask for an instrument, something is broken, and this keeps coming up, right? So what you would want to do in that case is apply exactly the same approach and try to figure out why does it keep coming back, right? Because this is impacting my workflow, it's decreasing my joy of doing this procedure, and it's harming the patient potentially or the one whose surgery is delayed. So if you can figure out, like, maybe it's because this thing, it just never gets taken out of circulation. Why does it never get taken out of circulation? Or how can we make sure it gets taken out of circulation? Maybe you can drop it in a tools bucket that's just for broken tools, and boom, it's out of that tray. Or maybe it's not easily identified. So there's a process to mark it, but it's like this big of a mark or something. And then you can implement something there. So, but basically the first thing that you have to do is, if there's a problem that you're dealing with, is just talk to the people that are involved. So that would be the OR staff, that would be the sterile core people, and see, like, what are their processes, what's going on. From that, you build a story of how this could happen, and understanding the surrounding organizational context, right? Maybe the trays are just humongous, and this never happens with one type of case always happens with another type of case. And so that helps you to understand and build some theories and maybe inform some directions that you can go down. Directly examine the process like the folks who've been to the sterile core have done. You see how they're actually doing this, and that might be informative. And then measure objective markers of performance, and that will be the next section that we'll talk to. Diagnose the root cause, and then fix it. So this is a clinical example. You can do this for any problem that you face in life. Maybe you're a terrible parallel parker, okay? Figure out why that is. You're turning the wheel left at the wrong time, okay? And then fix that, right? So fix that in a systematic way. So this is basically, when you're trying to treat a patient, it's problem solving. When you're trying to do QI, it's problem solving. It's basically just problem solving. So back to that sterile core case, and we're talking about the fiscal difficulties that the UW is facing. What was happening there is that the broken instruments and missing instruments, there's that little recipe sheet. The OR staff are supposed to indicate if something is missing or broken, return that sheet. That's how the sterile core knows that something is irregular with the tray. The problem is that they had been doing that for a while, had seen no improvement in the sort of trays they were getting back, so no one was filling those sheets in anymore. There was no way to identify the broken instruments so they kept coming back, and the OR staff did find a bucket to throw these things into. That was called the trash can. And so basically that was the way to permanently remove them from circulation. And then the sterile core went nuts because now they're missing instruments and they're having to reorder a bunch more. So the end result of that, the fiscal impact on Harborview, which is a dent in the bucket, really, drop in the bucket, was $250,000 per year. That's still $250,000. You know, it's not $45 million, but there's still a cost to that. And of course, it's a workaround, and it's not a permanent solution, and potentially patients are still getting cases delayed or canceled as a result of that situation. So the next thing is lack of formal mentorship or integrated education and QI methods. We'll focus on just one component, which is that monitoring the health of the system through objective measures. So we're all used to this. This is a cardiac monitor in wherever you happen to be with vital signs for a patient. This is usually on, or at least they're getting these same data at rough intervals throughout the day. Squiggly lines here and some numbers tell you at a glance how well this patient is doing. This one is not about to crump. Someone pause the alarm. I don't know what was alarming. This is kind of the same approach that we take in quality improvement. Bunch of squiggly lines, it tells you the health of the system, or tells you what you're doing to the system. So this is called a statistical process control chart. You don't need to know that, or the real simple things of it. But what it shows is that there's sort of normal variation across the system, but for the most part, it's stable. It runs within these two boundaries, okay? So whatever this is, this happens to be patient discharge time. So you'll see that most patients get discharged in this like example between 12 and 6, okay? So, like I said, quality improvement can be applied to just about any problem. If you have a problem, you can do this. The key thing is to be deliberate about it. And that means that you should have a data plan. That data plan doesn't necessarily need to involve going to Amalga and downloading a bunch, like 10,000 line lists on Excel, or doing massive statistical analysis. So this is from a personal improvement project. And basically, this is me. I don't know if people in the remotely can see, but it's obvious I don't work out that much. And I figured that in an effort to die later in life, that I should probably start running, okay? So this is like my first attempt at doing this. And it is trying to capture some data about how effective that is, or when I should move to the next level. And a couple of things to point out is that there's certain buckets of information here that I've listed as process measures, outcome measures, and balance measures. So this is sort of like how I'm doing things. This is what I really care about at this point. Longevity, I can't really put on here, but you know, kind of like the mood of the day and how much energy I'm feeling I can. So this is the outcome that I'm trying to influence. And then just to make sure by doing this, I'm not screwing something up over here, basically balance measures, right? So here I've got calories, max heart rate, and miles. Most people have Fitbits. I'm just taking snapshots of the treadmill in the GYM. I think that's how you pronounce that, because I've definitely never been there. So basically use the machines that you have to help you, right? Like I don't have to count while I'm doing this. I don't have to, I don't know, whatever you would do to figure out how many calories you've done. But the machines, we have technology that can help us do rapid data collection in flow with your work. I finish, this thing automatically comes up, pull out my iPhone, which I'm listening to podcasts anyways, and then get the screenshot and I can put that in an Excel spreadsheet. So outcome measure, again, kind of what I'm worried about. And then the balance measures, this is one that's hard to do when you're just starting out, but it's basically, again, to a clinical context, there are natural balance measures that you deal with all the time, right? So heart rate, blood pressure, those are natural balance measures. In medicine, sort of your diuresis goals, your creatinine. Maybe more pronounced in orthopedics, your pain scale and your respiratory rate, right? As you try to improve one, you have to monitor the other to make sure it's also not tanking. So that's basically what that is. So I have incomplete tasks. So how much time is this exercise taking that I'm not finishing stuff on my to-do list? Alternatively, I could have done this. How many times am I throwing up? It's not something I want to avoid. So basically what you can then do is take these numbers and just graph them out. And this is basically what that would look like. And that's informative. I always, Excel makes it easy, but I always recommend graphing these things. Number one, it kind of shows you how things are going. So maybe at this point, I should increase the intensity because I'm not hitting as high of a max heart rate that I want to be. The other thing is, looking at a graph shows you your progress over time, and there's a sort of joy that's built into that, right? So if you're just thinking about, like, how was my workout today? It's a different thing than if you look back at your trend and say, wow, I've made a decent amount of progress. And so there's a certain motivation intrinsic to this to help you continue the project. And again, data entry for this, I was just doing this once a day. That takes about 10 seconds. The photo takes less than that, and then this takes about 2 minutes or so at the end of every period that I want to look at to get this going. So you can do the same. So this can be patient discharge times for an actual quality improvement project. You see these decreases here. This is fake. This usually doesn't work. Early discharge order, that discharge by noon thing, and then early medication reconciliation, or something that you want to do to get home earlier, spend more time with the kids, finish your notes faster, yada, yada. All of that can be done here. And you see basically as you implement stuff, hopefully you'll see an inflection. So this is these are real data from the VA, just collecting information. Again, this takes about 10 seconds of data entry every time it happens. So we have a pneumatic tube system like most hospitals do that's used to transport various things, laboratory samples, medications. And this is part of what we call Project Suck. It's a vacuum tube system, but it's just a project to try and make sure this thing becomes more reliable. So it's still having outages, right? So every time this goes down, the team members, which is the technicians who are part of Project Suck, they go and log what happened. And so this is just for a couple of weeks. And then you'll see some patterns kind of starting to display themselves. And so whatever station this is, this happens to be pharmacy, it's generating a decent amount of the failures. The contents are drugs, not surprising because most of these are pharmacy. And then why are they failing? So this TU-202 piece of equipment needs to be replaced, obviously. So that can be taken care of, and we can eliminate some number of these failures. And then there's an issue with improper closure. So maybe that's something we need to take a look at the capsules themselves and make sure that people know how to close these things correctly, or do something to make sure that we can get them to close properly, right? So when these things go down, they may not be fixed till the next day. Then you run into trouble doing any sort of transport through the pneumatic tube system. So this is just kind of keeping daily list of things that go wrong. In the hospital, larger scale, this is what this is intended for. Its original name, PSN, you guys might know it, Patient Safety Network, its original name was System Intelligence, and it's supposed to collect intelligence about the system. The problem was when they shorthanded that was SI, and the folks at Harborview said that we don't want a system here called SI, so that's basically why they actually rebranded this for the UW system. So this is from the VA version of that. It's called the EPR. This is true data. So just looking at medication errors across the hospital for 2016, you see that we have kind of a problem here with missed medication doses on the evening shift when the staffing is lighter. So we can dig into that deeper about why that's exactly happening. So scarcity of time to engage in QI projects. So this is kind of the last section. It's basically application versus discovery in the world that we deal with. That's our primary job, bedside practice. I put this, I mean, it takes a lot of time. It takes, upwards of 80 hours a week, but it is our primary job. It's not extra time. If you want to do clinical research in ortho or general surgery or wherever, or medicine, you try to carve out dedicated time to do that a year and a half, 2 years, or whatever. And I think the same approach kind of applies to quality improvement. And this is what I would advocate that you guys think about. There is quality improvement research. The VA has a huge health sciences, HS R&D division that's sort of talking about very lofty things about ways that we can do better and deploying things across the healthcare system. But practical improvement is kind of what you can do on a day-to-day basis. And again, that's either hitting it in the clinic, just in terms of your daily workflow. It's something you have very tight control over just so that you have better enjoyment of that day, or can be directed towards wellness. Remember, ACGME also cares about wellness. Dr. Bess, who is the associate dean that we heard about, that's her actual job, is for wellness. So if you direct some of this energy towards improving how you do things in your clinical arena that has benefits to wellness, that's a twofer in terms of what the ACG cares about. So think about that. And then there's intrinsic motivation, obviously, if it improves your quality of life. But so if you want to do something like develop a new payment model for joint replacements, or that the IPASS project that you may have heard kind of talked about, that is more on this side of the spectrum with like true statistician support, PI or co-PIs doing that. You should carve time out. Like that should be a year-long activity. This kind of thing you can kind of do over here, and certainly I want to get my notes done 15 minutes faster. This is something you can do. And that's what I advocate. You practice these QI skills on this end of the spectrum, or fixing how you parallel park. Practice those things on this end of the spectrum. That stuff is a lot easier. So this is one thing that we did. This was for a talk at Boise where we were saying, how do you integrate this into your daily workflow for the medicine teams as they're rounding? It was just add the hospital as an extra patient on your list. And this was a project where we were having issues with cardiology patients on diuretics for heart failure, not having weights obtained in the morning. So this is just your daily collection plan. So as you're checking off things for the rest of your patients, this is one thing you can do on a daily basis here. Just add it to your patient. This is a rock that will never leave your list, FYI. So as you spread change, that's sort of that triangle of research versus practical improvement. You're not aiming for this, which is a randomized controlled trial. What you're basically doing if you do a successful quality improvement project is a case study. And the reason for that is you're not trying to test, in terms of a patient with sepsis, you're not trying to test if Zosyn is effective. What you're trying to do is take something that is known or something that makes sense and applying it, adapting it to local context in order to derive a result that you want. And that's basically what practical QI is. That adaptation, for instance, is if the patient has a penicillin allergy, you will not give that patient Zosyn. Here, if the issue is that we are understaffed, one solution is to hire new staff. If we have no money to hire new staff, then your solution becomes cross-training. All of the time, your goal is for the patient, discharge. For this situation, fix the problem, right? So that's the approach to QI. Ways that you can participate sort of across the system is if you do QI research or case study, any of these kinds of things, and you can feel free to write it up. They will publish case studies in QI. BMJ Quality Journal is one. But we have our local thing as part of the House Staff Quality and Safety Committee. Recommend you check it out, uwhqsc.org. We do this once a year now, probably twice a year. This is our local journal. This is the newsletter that accompanies that. And then QI Match, actually this couldn't have been possible without Dr. Chansky's help and Aaron's help. They're developing this, Aaron and Jason are developing this as hopefully a future module potentially to eMetrics. But the idea is that this is a way that you can post projects, get people to help you with your projects, join a project that someone else has started. And the nice thing about this is this will ideally store your participation for reporting in the future. So it's basically QImatch.com. It's not yet ready for prime time, but when it is, you guys, I'm sure, will be among the first to know about it. And I think that's basically all I have here. PDSA cycle, this is the main thing you'll hear talked about a lot. In quality improvement, evaluate the system, diagnose the problem, do an improvement plan, monitor key parameters, and then iterate that to fix the problem. This is the same thing you do with patients every day. You evaluate the patient, diagnose the problem, develop a plan of the day, come back, reassess how things look, and then you make some small changes until they get better. So summary, as a physician, you already possess the essential skills to conduct QI, and then to succeed, you need to elicit a history, understand the context, go and examine things for yourself, track those measures, identify the root cause or diagnosis, and then deploy interventions matched to the local constraints. And if you want to do QI research, you will need protected research time. Otherwise, practical QI should be extremely simple. Should take about less than 10 minutes of your day, hopefully less than 5. The hardest part is thinking about how to do it in the first place. That should be done over coffee on a Saturday morning when you have free time. Okay, so summary, patient care is quality improvement in a biological system, and quality improvement is the same thing as patient care in a big building with lots of IV poles, and that's it. Okay?